But here's a slide, just 1994, 1995 hospital Medicare data, and this you might not be used to seeing this kind of slide, but essentially each dot represents a hospital region and how often they're giving beta blockers to people who need them for survival. And you can see the best hospitals in the US, 3 of them are up in the 80 to 100% range. Nobody's at 100%. You can also see that lots of hospitals are down at the bottom and provide beta blockers for almost no one. And that's of course because the beta blockers, you know, were off patent and nobody was making a big profit from this. So I'd like to suggest that there are 2 ways that we tackle this problem. One is that we think more and more about using information technology and decision support systems. And the second is that we incorporate into our information technology mechanisms to enhance shared decision making. Decision support systems are used all over the country now in general medical care. You know, you probably are all familiar with the data that we kill about 100,000 people a year in hospitals from medical mistakes. And one of the biggest causes for these medical errors is that the prescriptions are misread, or the doctors prescribe a medicine that interacts with some other medicine that the patient is already on. And studies show that if you educate doctors again and again and again about these interaction issues, they can master about recognizing about half of the dangerous interactions. So that means the best doctors are still unaware of the other half of the dangerous interactions. On the other hand, if you just ask them to make their prescriptions through the computer recognizes immediately that there's a dangerous interaction there, or that the doctor has by mistake put the decimal place in the wrong place and given the prescribed medicine at a dose that might kill somebody. So we eliminate a huge proportion of medical errors by this simple use of information technology and electronic decision support systems. And this is, you know, gaining ground virtually everywhere. I think, you know, just we like to be last among the 40 industrialized countries in healthcare. And the other 39 are actively working on, you know, implementing standardized electronic medical records across their healthcare system. We're slowly inching toward it, and I'm sure Obama is going to get bashed for recommending it by those who might lose money on the proposition. There are really 3 critical elements in high-quality healthcare. There's paying attention to the patient's preferences, there's paying attention to the research evidence, and there's clinical expertise. And all of these 3 elements are supposed to come together in decision making. The problem is that the research evidence is usually not anywhere to be found. Those of you who have gone to evidence-based medicine conferences where we try to teach doctors how to do rapid searches and find the evidence, you know, the way we run these conferences is, and I've done this for psychiatrists every summer for years, I'll give them a very common situation and they'll all say, well, there's no evidence on that. And so then we teach them how to do a quick search, and they find that, well, there really is a right answer to lots of common clinical situations. And they've been making decisions every day on a common problem for years without knowing that there was a right answer. So we've got to get the research evidence to the clinicians. You know, expertise alone doesn't do much. In fact, all the evidence suggests that the longer people have been out of medical school, the worse their outcomes are, and the worse the quality of care they provide is, because they don't keep up very well, or they even keep up in a negative fashion by getting their information from drug representatives. Similarly, it's very hard for patients to express their preferences in the current situation. You know, How can you have a preference for care when you don't know what the alternatives are and you don't know what the outcomes and the side effects are? So the way we think around this is to provide electronic decision support systems that can get good information to everybody at the point of contact. Let me just give you an example of this. In our hospital at Dartmouth now, everybody that comes in for a medical appointment goes to the Patient Education Center first, and there they have a chance to access videos, and they have a chance to access the latest data on their medical problem, and they have a chance to access their medical record, and they put in how they're doing and what they're concerned about, and all that information goes directly to their doctor, so when they meet with the doctor doesn't have to go through the usual thing of, wasting 90% of the visit asking standard questions. They've all been asked already, and so whether they've got 15 minutes or half an hour, they can look at the data together and try to make a decision about what's a reasonable next step. So doing it this way, we've had some miraculous outcomes. The orthopedic surgeons actually recognize that people have depression because it's right in front of them on the screen, and they refer people to psychiatry for treatment of their depression. The psychiatrists actually recognize that people who are in treatment for depression are not getting any better because the client is putting in their symptoms each time they come in. We don't have to look for the record, which can't be found, and there's no standardized measure on it anyway. The patient enters the standardized measure, can see exactly how they're doing, and when the psychiatrist and the patient look at this together, and the screen also tells